The key to me is never giving up. When you've got a loved one who has frustrated you to no end because they've been in and out of treatment programs 5 times, 6 times, 7 times, and you're just sick of them and you want to throw your hands up and throw them out, don't. Recognize that the only way this illness defeats people is when we give up. We can always try again, because that's how you can prevent the most horrible outcome of this illness.
Substance use disorder touches all our lives, and often we feel hopeless or frustrated in our pursuit to understand how and why it happens.
Welcome to APC Recovery Cafe, where we discuss the topics and trends around substance use, provide education and resources, offer recovery support, and also discuss prevention tactics, all through the stories of the people who have been there.
We invite you to grab your favorite coffee or tea and join us for a variety of guests that will bring understanding, information, connection, and hope.
Together, we can break the stigma and pave a brighter future for each other.
Hi folks, welcome to this episode of APC Recovery Cafe. My name is Art Wimberly. I'm a person grateful to be in long-term recovery. I'm a volunteer at the Addiction Prevention Coalition, and today on this episode I'm with my co-host Carrie Wimberly, the Executive Director of APC. Carrie, do you want to introduce our guest?
Sure. Good morning, Arthur.
Hello, Carrie.
Excited to be here today, and more excited about our guest, Dr. Taylor. Dr. Taylor is on our board at APC, and there is no possible way I'm going to get through this bio. It would take most of our time.
Take a shot.
Okay, so I'm going to try to hit the highlights so you guys can get a feel of who Dr. Taylor is and his experience and wealth of knowledge that he brings to this conversation. He's a psychiatrist with over 20 years of practical experience. He was has become part of our board because of his work with adolescent and young adult patients and their families afflicted with drug and alcohol use disorders. He's an honors graduate of Harvard College with a bachelor's degree in history and science. He earned his medical degree from Howard University College of Medicine. Then he earned a Master of Public Health degree from Harvard School of Public Health, and if that's not enough, he pursued a triple board residency training in pediatrics, general psychiatry, and child and adolescent psychiatry at the Albert Einstein College of Medicine in the Bronx, in New York, and he completed subspecialty fellowship training in alcohol and drug abuse treatment in New York University.
And This was all before he was 20.
Yeah. And I just learned in our pre-conversation that we're the same age, and so I'm thinking, man, I really should have gone back and gotten a few more degrees. Wow. And there's a lot of other things here, but the thing that I do want you to talk a little bit about, Dr. Taylor, is you're serving as the medical director of the Player Assistance Anti-Drug Program of the National Basketball Association and the National Basketball Players Association. And I did not realize, as long as I've known you, that this is a program that you designed and implemented. Tell us about that?
Yeah, let me clarify.
Yeah, clarify that.
I mean, the program actually existed long before I ever became a part of it.
Okay.
I'm actually, to my recollection, I believe I'm the third medical director that the program has had.
Okay.
The previous one was in the position for 16 years.
Wow.
And so when we talk about how we designed the clinical program, what I mean is that the program is laid out, the rules, the strict sort of legalistic rules of the program are laid out in the collective bargaining agreement between the NBA and the NBA Players Association. But when the previous medical director passed away while in the job, in his 16th year in the job, there was no real communication with me at all about how the program had run previously and how things were supposed to work. So when I came in with my team, to figure out where do we pick up and try to provide treatment for these players. All we had was the legalistic sort of rules of the program as laid out in the collective bargaining agreement. So the clinical program, how do we evaluate a player when he comes into the program? How do we find and assemble a network of clinicians in every NBA city to whom we can refer a player who might need care? How do we develop the criteria by which we will select those clinicians and interview them and vet them and make sure that they are the type of people who are of the quality to provide care for these players? How do we also evaluate and assess the quality of treatment programs, whether it's intensive outpatient programs or inpatient treatment programs in various parts of the country to which we can refer players if they need treatment? All of that was something we had to come up with ourselves.
Okay.
None of that was passed on to me because, unfortunately, the previous medical director had passed away while in the job almost a year before I started the job. So that's what I mean when I say we designed the program.
So it's building it out, really.
Right, really, exactly.
The resources that the players need so that they can be successful.
Exactly. And then the whole procedure for following players up and making sure that they keep the appointments that they make with their treating clinicians and that they make those appointments. I mean, let's face it, we all know that a person who has a substance use issue is very often ambivalent at best about getting treatment, about wanting to stop. And so that requires encouragement and
accountability.
Holding people accountable and all of that. And so designing the whole procedure by which we provide that for players, all of that was stuff we had to do ourselves. So that's what's meant when I say that we designed the program. It wasn't just that we made it from scratch. It did exist previously, but designing the whole clinical intervention of how we provide this care for players and make sure the players get the care that they need. And again, do so in as discreet and as respectful a way as possible. All of that was the part that we came up with.
We usually start out by talking about what their favorite beverage of choice was. You can't really talk of that, but because you didn't tell me what kind of smoothie. You said smoothie, any kind of smoothie.
Right.
So this one happens to be an angel food smoothie from Smoothie King, which I just went through and just said, give me the most popular smoothie you have. So it's pretty good.
It's delicious. Oh, yeah.
I need to go get one for sure. Okay, so then we try to figure out the beverage of choice, what it tells us about the person. So what is smoothies? I always love smoothies.
In my case, probably it's not all that profound. My addiction happens to be to sugar.
Oh.
See? And so smoothies give me a chance to have my drug of choice.
Well, and they sound kind of healthy because you have a
That's
smoothie.
Right. That's right. You have the cover of it being kind of healthy.
Especially if it's green.
Right. That's right. And in fact, I've gone, it's so funny, recently my counselors and I were in meeting a team out in, actually I think we were in New Orleans at the time. We were meeting with one of the teams to do the prevention work that we do with them. And there was the hotel that we were meeting with had staff that were preparing smoothies. And so I asked this woman, I said, okay, I want you to put some spinach in there and put all these different vegetables in there and all that. And then she asked, well, so you want me to not put any sugar in there? I said, well, wait a minute. Let's not
hold
carry
on.
away. Now, I want this to be healthy, but let's not,
Let's not go overboard on this.
Yeah, exactly. So I think that's the magic of smoothies is it allows me to, with a little bit less guilt, still indulge in my drug of choice.
It doesn't take as much denial as normal.
Exactly.
Okay.
All right. So obviously prevention is a big deal to you. There's a passion. We can see it in the room right here, which I guess explains a little bit about how you got connected to an organization like the Addiction Prevention Coalition, where you serve on the board. But the NBA work, the work on the board of APC is just a couple of places that you operate in now in terms of prevention and recovery. We'll talk more in detail later, but I'm going to assume that as you were growing up, you didn't always have that in mind, that your field of expertise and your passion was going to be addiction, whether it's prevention or recovery. Can you tell us, go back, tell us your story a little bit, bring us forward, and then maybe highlight where did that angle kind of change for you?
Well, it's funny you say that when I was growing up. I kind of was always when I was growing up. Here's the way this happened. It's really, this is really true, and a lot of people find this kind of strange. I grew up in a neighborhood of Brooklyn, New York, called Bedford-Stuyvesant. And at the time that I was growing up in Bedford-Stuyvesant, there was also an opioid epidemic taking place, but it was an opioid epidemic that looked very different from the current one. It was concentrated primarily in inner city communities where people of color lived, and you would see the prototypical person, on the streets of some of these communities who was, sleeping it off on the side of the street with a brown paper bag or was nodding out on a corner. So that's where I grew up in Bedford-Stuyvesant during that time. And so my earliest memory was and I couldn't have been more than about five, maybe 6 years old, walking down the street with my mother, Sumner Avenue, which was I lived on Madison Street between Sumner and Lewis Avenues in Bed-Stuy, and we were walking down the street down Sumner Avenue. My mother's holding my hand, and we passed this guy who's standing on the corner, and he is, sort of slumped over and looking half asleep and looking like he might fall over at any moment. And he caught my attention, and I just started staring at him, in part because I'm thinking he looks like he's going to fall. And I wanted to see if he was going to fall or if he was going to be able to avoid falling or whatever. And my mother noticed that I was staring at him, and she says to me, "You see him? He's probably only about 20 years old, but he looks like he's 60. And she said, and he looks like he's about to die. She said, that is what drugs do to people. Whatever you do, don't you ever do drugs. Don't you ever use drugs." She didn't say do drugs. She said, don't you ever use drugs. And so I thought about that, and I was looking at this guy who looked like he was about to fall over and looked, again, half asleep, half conscious, And I thought to myself, okay, Mom, I won't use drugs, but I was much more interested in the fact that this guy might fall because this was concrete. This was Brooklyn. And
that's prevention already.
So I thought to myself, if he falls and hits his head on that concrete, he's going to need a doctor. And I had already decided, even at the age of 5, that I wanted to be a doctor when I grew up.
Oh, my God.
And so in my head at that moment, I thought, that's it. That's the kind of doctor I want to be. I want to be the kind of doctor to help guys like him. And
so it was implanted early.
I remember that thought happening at that time. And so here's the thing, though. This is the thing that I think really was so important about that moment. It wasn't so much what my mother said about this is what drugs do to people, don't ever use drugs. It was the things that she didn't say that I think that were most impactful. She did not say, look at this disgusting character who's littering the streets of our neighborhood. Look at this evil stuff that these people do, these drugs and this alcohol, and look at these guys, these bums that are on us. She didn't say anything like that. She didn't make any disparaging comment. She just said, this is what drugs do to people. Don't ever use drugs. Yeah. And I think that unwillingness or refusal, if you will, to say anything disparaging or to look down on this guy in any way, but instead to see him as someone to whom drugs did something, was what was really implanted in me. So then my next thought was, okay, well, if I'm going to be a doctor, why not be a doctor to help guys like him? So that's, I think, the earliest implanting of that thought in my head that probably led ultimately to what I've become.
One of the thoughts, knowing that you were going to be here this morning, that I was excited about was to explore prevention, because we are able to talk to fascinating people here, but there's not many preventionists that come through. And just as you're talking about the prevention points in the work that you're doing with the MBA, I'm reminded of, what we do at APC around the similar concepts, and that is really doing all the education that we can, parents and students, to delay that first use. That's so critical. Any year that we can get them past starting so early makes a difference. But I'm also was reminded as you were talking about, one of the hashtags that we use in our prevention campaigns with the students is protect our future, and helping students to begin to think about, get off these screens and begin to think about, okay, what is it that I want to do with my life? Do I have a dream? And what would that dream look like? Once they have that, and firmly implanted, then delaying those things or making different choices so that they're going toward something is such a powerful prevention technique that we try to use in the schools and as we're talking to students. But then another one is genetics. We have to talk about genetics and be aware of that. So people say, okay, if I'm genetically predisposed, then I'm just going to be addicted. But that's not true. It is the education around we need to be aware of that genetic predisposition so that we are making different choices. So can you talk just a little bit about that?
Sure. First of all, you made me think of a vignette that I'd like to share real quick when you were just talking about genetics. So I was at an addiction conference some years ago, actually many years ago now, but it was an addiction conference for doctors who were trying to get continuing education in addiction. And I met this woman who was an addiction specialist herself and physician, and she talked about the fact, and I don't even remember the context of why she was talking about this, but she talked about the fact that both of her parents had severe alcoholism, severe alcohol problems, and she remembered that when she was in college, she found herself on this one occasion hanging out with a bunch of the school's athletes, male and female, but a lot of male athletes, football players and basketball players, big guys. And they were all drinking heavily. And by the end of the night, she had, to use the old proverbial phrase, drunk all those guys under the table. In other words, a lot of those football players and basketball players were passed out, were just, had way been knocked out by their drinking. And she, who had consumed as much as they had, was still going. And she said, that night, she said, I realized this is a problem. This means that I'm at risk. If I can drink all these guys under the table, this means that I'm at risk. And the fact that both of my parents have alcohol problems and I can do this means that I'm going to end up just like them or worse. And she said that day she made the decision never to drink again. And she has never drunk again since that time, and then went into the field and became a physician who specialized in treating people with addiction. So that vignette came to mind when you talked about it, because that is sort of the quintessential story of the genetics of addiction, or the heritability of addiction in my mind, which means this: the number one risk factor for developing an addiction problem is to have a parent who has or has had an addiction problem. That's the number one risk factor, right? Or by extension, a strong family history of addiction. But it is not at all inevitable, because as with so many things in medicine, you've got to have the genetic heritability and the environmental exposure and involvement.
In other words, it's not deterministic.
Absolutely not.
But it is a big factor.
It's a big factor. It puts you at a higher risk category, but you can make the decision to alter your environment, i.e. not engage in substance use, such that you will guarantee that you won't ever develop that problem. And that's what that woman displayed, was that recognition and taking a step back and saying, you know what? That's it. I'm going to make the decision to do something that's going to prevent me from having this problem, so it will not be inevitable in my life. And in my work with young people in particular over the years, particularly, the 13 and 14-year-olds who are doing some drinking, smoking some weed or what have you, that's very often one of the conversations I have with them, because as you might imagine, for many of them, there's a parent or a strong family history of addiction. And what I'll say to many of them is, look, I understand that a lot of kids your age are doing some drinking, smoking a little weed, doing some other things, smoking some cigarettes. You need to understand that for a lot of people, that's not going to end up being a lifelong or life-shortening problem. You're different. You're in that high-risk category. You can't afford to do that. You need to be the one that says, you know what? I'm not going to get involved in that. I'm going to make different choices because that's what I need to do for my life.
Yep.
And so that's, to me, the important message for young people who are at increased risk, because it's if we can identify what those increased risks are, one of them being what I just said, family history, parentage, but also a co-occurring general mental health problem.
Yep.
Young kids with mood disorders or ADHD are significantly increased risk for developing an addiction problem. Kids at either extreme of the socioeconomic ladder are at increased risk.
Yes.
Kids who have a lot of friends who are involved in substance use, they're at increased risk. We know what many of the risk factors are.
Right.
And so when we have youngsters that we're aware of who have Siri got all worked up about this topic. She has opinions too. When we have young people and we know what the risk factors are and that they're at increased risk, we can use that as the way to help us target our interventions to those young folks and target our messaging to say, hey, look, I know lots of other people are doing it.
Yeah.
You're not like them. You're in a different category. You probably more so than other people need to make different decisions.
Yeah. And I think we love and try to get in front of parents and grandparents as much as we can. We have to get creative sometimes, but one of the things, or several of the things we like to talk to them about is one is perception of risk. We've seen a real decline in perception of risk around substance use in adolescents, but we've seen it in their parents as well. So, reminding parents that even though their teenagers act like they're not listening to them, they are the number one reason that children decide to not use alcohol and drugs. So being consistent and that messaging in the home is critically important. But also, when we're talking about the opioid epidemic, which, we're seeing the evolution of that with the fentanyl crisis now, being with your child when they have their first experience with an opioid, if they get their wisdom teeth out or they have a sports injury or a surgery, and being able to have that conversation with that teenager, okay, how did that make you feel? Because we now know that people have different reactions to opioids. Our son that was an opioid addict, had that euphoric experience when he took one. When I take one, I feel horrible. People don't realize we're not all the same. Our brain is not wired the same.
That's right.
And the reaction to that is critically important to what your future is going to look like and how you have to be very careful with those medications and having those conversations with your physician. So can you talk about the brain a little bit or about the differences there?
Sure. So one of the things that we talk about all the time is that addiction, and this dates back almost to the last century, really. Addiction as a brain disease, right? Addiction as a medical condition that is treatable and controllable, but not usually curable per se.
Yeah.
And as a condition that can be chronic and can feature recurrences, alternating with periods of remission, just like any other chronic medical disease, right? And the one that we most commonly compare it to, of course, is diabetes, right? And so, but what people need to understand is that also means that if you have, 5 people in a room, not all of those people are going to be equally susceptible to addiction. The same way, not all of them will be equally susceptible to diabetes.
Yep.
And so the whole point that even opioids, even with this crisis that we're dealing with, your recognition, because I'm the same way, we don't all respond to opioids the same way. I had to be treated with an opioid some years ago. It made me so nauseous. I just knew I wasn't taking any more of that, no matter how much pain I was in.
Yes.
Not everybody has that experience. Some people feel such euphoria from it and think, oh my goodness, this has solved every problem I've ever had.
This is the way I'm supposed to feel.
Right.
Well,
and I'm
that's
always
the
wanna
exact
feel this way.
phrase that when our son got sober, by the way, it was a 15-year journey for him. He was an IV heroin user by the time he was 19. But that's exactly when he was able to reflect back, that first legal opioid taken for something, that made him feel like this explains life. This is the way you're supposed to feel, and I got to figure out how to feel that way.
Right.
And that's what he chased for a long time.
That's right. And that is the way it is. And then there are some different stages in between that too.
Yep.
I've worked with some people who said their first experience wasn't all that exciting. It wasn't all that unpleasant either. And they had friends and associates with them that said, well, you just keep trying it and then you'll really get to like it. And unfortunately, they listened to those friends and that turned out to be true. So it can be various different experiences. So we're not all the same.
Yeah.
Can you talk a little bit about, in some of your talks that you've given before, you kind of delineate this idea between what we might call the classic addict, okay, that maybe does have a genetic predisposition as well as some other factors, trauma, some of the other things you've listed that combine to make it kind of a full-blown addiction. But there's kind of a spectrum there in which we can go from almost zero to that, but in between, not true addict, but abusing or overusing a substance to their detriment. Can you talk a little bit about that spectrum?
Absolutely. So what I think what you're referring to, I had a slide that I've used called the drug use spectrum.
Yes.
And there's a large percentage of people who engage in experimentation.
Yep.
Right. And then there's a smaller subset of those folks who engage in sort of occasional use of a substance, and then an even smaller subset who engage in regular use,
right?
And then an even smaller subset that engage in habitual use or constant use, and then a smaller subset of them go on to addictive use. And usually the point that I'm making when I present that is the fact that people need to understand, particularly parents, particularly ones whose young people are still in that experimentational stage, that death can occur anywhere along in that spectrum.
Right.
Okay, we have in this country, and I haven't studied the data recently, but the last time I studied this and was doing presentations on it, it was around 1,800 college students every year in this country who die from acute alcohol poisoning. Okay, and that can happen, and that's throughout America's colleges and universities. Roughly 1,800 students. A subset of those students are ones who only tried alcohol for the very first time. Mm-hmm. If you drink enough, and a lot of times the college drinking games that young people engage in, where they stick a tube all the way down the esophagus so that they have a way of bypassing the body's natural way to have the esophagus contract when that poison's going down in there to make them vomit it up. If they can bypass that and get the alcohol all the way down into the stomach, so you've bypassed the body's protective mechanisms, well then now a whole lot more can be absorbed into the bloodstream a lot faster, and which can then result in you getting enough alcohol in that it will kill you. Yeah. So that's an example of that kind of experimentation or early use has far before anybody's been able to develop an actual addiction problem,
Right.
But it can still be life-threatening, and that's kind of what I try to prove.
Yeah, and in the current era that we're in with opioids and especially fentanyl, and now it being placed into other drugs or what are sold as other drugs, then that above alcohol is even starting to spike these accidental deaths, so to speak.
That's right. So the what used to be thought of as mainly harmlessly popping a Xanax, a single Xanax that's just a relatively low dose that you feel pretty confident is not going to cause you that much of a problem, but maybe give you a little buzz. Well, that Xanax could actually be fentanyl, all right, or have a fentanyl analog that's in it or that's really masquerading as it,
Right.
and you end up with a dead teenager.
Or a student in college needing to stay up and cram, taking Adderall or something like that for something non-prescribed,
Right.
but yet it's also laced
That's
as
right.
well.
And that can be, anything can be laced, and that's the problem. And that people need to understand that nowadays you can't even trust. Not that we should ever have thought we could trust the person who's giving you drugs, but you can't trust what you think you're taking.
Right.
Yes.
You know, and so the really the safest solution is not to misuse any substance. If you really do have attention deficit hyperactivity disorder or narcolepsy, and you need to be prescribed a stimulant medication, you need to do that the right way with a doctor's prescription and only take it as directed. And even then, you know, all medicines have risks. All medicines have potential side effects. And that's one of the things that I, throughout my career, spent a lot of time talking with parents and patients alike about that reality. Even if you're doing everything the right way, people can have adverse reactions to medications, and it's really important to know what those are and to take action immediately.
What's the last thing you'd like to say to somebody listening to something like this in terms of either getting help or being part of the help?
I think people need to recognize that addiction, I mentioned it as a treatable and controllable illness. It's also a preventable illness. And since this is the Addiction Prevention Coalition's podcast, it's important that people understand there are some principles that we can apply to prevention. First of all, you got to understand that there's primary prevention, intervening before any problem has ever started. There's secondary prevention, intervening a little bit after a problem has started, but it hasn't gotten real far. And then there's tertiary prevention, which is essentially treatment of the condition, and what you're preventing is the potential really tragic consequences of the illness. All three levels of prevention are extremely important. And whatever situation a person may find themselves or their loved ones, there's help available. They got to keep asking for help. And basically, the key to me is never giving up.
Yep.
Okay, when you've got a loved one who has frustrated you to no end because they've been in and out of treatment programs 5 times, 6 times, 7 times, and you're just sick of them and you want to throw your hands up and throw them out, don't. Recognize that the only way this illness defeats people is when we give up. We can always try again. You try differently. You look at what mistakes you may have made before or what may have gone wrong before, and you try to do it differently the next time. Because we all understand that the definition of insanity is to do the same thing over and over again and expect a different result, right? So don't do the same thing.
And one size doesn't fit all.
That's right. Yeah. But you don't give up. You always keep coming back. You always keep trying, because that's how you can prevent the most horrible outcome of this illness, which, as we all know, premature and avoidable death.
Yep.
Carrie?
Thank you so much. And now, clearly this is why Dr. Taylor is on our board, and we get him to come and talk all the time in our things, because you are so aware and articulate about prevention and about what is needed in education and support and recovery. So thank you so much for taking time out of your busy schedule to be with us today. We really appreciate all that you do.
My pleasure. Thank you for inviting me to be a part of this very important podcast.
Thank you.
Folks, thanks for joining us this time on the APC Recovery Cafe. We hope to see you soon with another exciting guest.
One of the things that APC is known for is being a connector, because we're stronger together.
Not only are we there for those who are suffering through substance use disorder, but we're there for family members, and we really take our job seriously.
We all have personal reason why we're in this field. We're changing people's lives one community at a time.